We are your hosts, Nicki Shore and Jesse Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, FAPIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research. Hey, Nicki, how are you? It's so good to be back.
Good. It's good to have you back, Jesse. I had a great time with our guests last time, but of course, it's just not the same without you, so I'm glad to hear your voice again.
Aw, very sweet as usual. I don't know if you did a joke last time, but I have a joke for today.
Oh, okay. Shoot.
What did the nurse tell the surgeon when he asked her how the girl who swallowed some coins was doing?
I have no clue.
He said, "We haven't seen any change yet."
Okay. Woo.
You gotta love our jokes.
Jesse's back, guys. Woo!
And with her super fun jokes, yeah.
I love it.
I did miss being here with you last month, but I heard you did have awesome guests and an awesome conversation. And I know that we are going to have more awesome conversation today with our guests, Dr. Sara Reese and Jordan Zepeda. Mm-hmm. Jordan is co-author of the article with Dr. Reese, Addressing an Increase in Surgical Site Infections During the COVID-19 Pandemic, Identifying Opportunities During a Chaotic Time. And what a chaotic time it was. Dr. Reese has been the Regional Director of Infection Prevention for Intermountain Health since January of 2021. And before that, she was the Manager of Infection Prevention at Swedish Medical Center in Inglewood, Colorado. And she held that role for 2.5 years. In that role, she led the COVID-19 pandemic response for the Level 1 Trauma Center and oversaw numerous performance improvement projects that resulted in a reduction of healthcare-associated infections. She mentored numerous masters in public health students through shadowing, practicum, and capstone opportunities. Dr. Reese also worked at Denver Health Medical Center for 6 years as an infection prevention specialist and at the Colorado Department of Health and Environment as the Patient Safety Program Coordinator for 2 years. She has published numerous peer-reviewed journal articles and presented at many local and national conferences on infection prevention activities. Most recently, Dr. Reese has published on the challenges within recruiting, hiring, training, and retaining infection preventionists, which is an awesome topic, and we would love to hear more about at some point. And our other friend, Jordan, graduated from Carroll College in Helena, Montana in 2014 with a Bachelor of Health Science and a minor in biology. She completed her MPH from the University of Montana School of Public and Community Health Sciences in 2019. Jordan currently manages the infection prevention program at St. Vincent Regional Hospital in Billings, Montana, where she focuses on surgical site infection prevention, process improvement, data analysis, and program management. Outside of work, Jordan enjoys spending time with her family, which includes her husband, 3 adorable children, and 1 very energetic dog. Jordan and her family love to camp, hike, and enjoy all the beauty the great state of Montana has to offer. Welcome, Dr. Reese and Jordan. We're so excited to have you here with us today.
Thank you. We're excited to be here.
Thank you so much. Super excited.
The article begins by highlighting the challenges that hospitals, particularly in the perioperative department, underwent both during the early pandemic when elective cases were canceled and ORs were shut down, and in the time following when procedures resumed, but in the setting of this new normal. Jordan, can you start us off by telling the listeners what prompted this acute care hospital to perform this retrospective cohort study?
Yeah, so we started to see an increase in our SSIs in late 2020 through early 2021. And at that time, we knew nationwide there were increases in CODIs and CLABSIs during the pandemic, but we weren't quite sure why we would be seeing more SSIs as well. We weren't really seeing that reported out nationally the way that the increases in CLABSIs and ICUs were being seen, right? As our IP team reviewed these SSI cases, we weren't finding any immediate obvious pattern or answer. It was across all sorts of different surgical specialties. There wasn't one kind of organism or one kind of procedure. And that really led to the need to do some further data analysis. And then we had this great opportunity to partner with Tracy Plummer as she was working on her MPH with Sara, and she's our other author on this paper. And she was able to look at all of our data comprehensively, which gave us a better sense of what was going on.
That's great.
And before we dig deeper into the study, Jordan and Dr. Reese, let's acknowledge that COVID created some pretty massive resource shortages and limitations. You mentioned in the article blood components, staffing, case backlogs, and stuff like that. Were there any supplies such as CHG wipes or antibiotics that were affected as well?
We weren't really aware of any specific OR supplies that were back ordered. However, 2020 was a little bit hectic and chaotic for all of us IPs. So it was hard to remember back then what impact we had. There were a lot of back orders, as we all know, a lot of PPE shortages, a lot of supply changes, and we just had to make decisions on the fly. So while I can't specifically speak to CHG wipes or antibiotics that were affected, we do know that there are a lot of just downstream impacts from having shortages across the board in our entire facility. So it's plausible and likely the products were substituted at some point in time. The supply chain disruption was super. And we even had our OR team sewing masks early in 2020 because we were just trying to get by at that point.
Trying your hardest. Yeah, absolutely. I remember those days. And similarly, I know that the post-op protocols were shortened in order to discharge patients quicker and reduce exposure to the hospital environment and thus COVID. Wondering if you think that, we'll get into the study, but do you think that contributed to it as well? Maybe patient education on wound and surgical site care was impacted?
Yeah, I think that's a great question and a great point. We didn't specifically look at that piece in the study, but it's very likely that impacted the outcomes as well. And just the general disruption to the healthcare setting, even with not having visitors present a lot or reduced number of visitors, that could also impact your discharge education, right? Maybe the person who's caring for you wasn't around as much because of COVID, and so they didn't get the same education. Another related factor I think that your question made me think of is staffing and staff turnover. Again, not something we looked at in the study, but we know that healthcare organizations across the nation struggled with turnover and staffing throughout the pandemic, and they still do today. And so that makes you wonder about the impact to some of that education for those patients going home as well.
Sure, it's not just lack of staff, it's different staff doing different jobs. So you may have people working in that area, in that post-op area, that aren't as familiar.
Yeah. Also in Nicki, how many locations had a lot of people that were traveling? So then you have staff that may be familiar with the high level process, but not necessarily with the process that your hospital specifically follows or the products that you're using. So I think there's a lot. Yeah. So the article mentions the list of patient medical records that were reviewed for the surgical site infections were generated based on ICD-10 codes that are defined by NHSM, which makes sense, and used some exclusion criteria. The reviewers that abstracted what were termed non-modifiable and modifiable risk factors. Can you talk a little bit about what those were and what that means?
Yeah, sure. So we wanted to look at what are risk factors in the OR that we can impact, we can drive change, and we can change a process where we can educate on specific areas of prevention tactics, that sort of thing. So that's what we considered modifiable risk factors. Is there something that we are supposed to be doing for our patients and we aren't? And so we had a list of those, and those included your pre and post-operative temperature, so maintaining normothermia, checking the pre and post-op glucose, having glucose management, because as we know in recent guidelines that came out that we need to be managing the glucose for all of our patients, not just specifically high-risk patients. Using the CHG wipes preoperatively, looking at what skin prep product we used in the OR for the case, and then, of course, appropriate antibiotic and timing for the procedure, which is always a complicated issue. And then, of course, there's other non-modifiable risk factors. So those are risk factors that, as healthcare providers, we really don't have any opportunity to do anything differently. The patient is the patient, the case is the case. And that's going to include the age of the patient, the BMI, the sex, if they have diabetes, surgery information. So such as the length of the surgery, what was the wound class, and what was the urgency? Was it an elective case? Was it urgent, or was it an emergent case?
Great. Thank you. That's great clarification. And then for those modifiable risk factors that you just mentioned, did the hospital already have policies or procedures in place to guide evidence-based practices around those?
For most of them, we did, and we were a bit surprised to find as many opportunities as we did, thinking that we were a bit more standardized. But when you get the opportunity to look at 8,000 cases, you find out how standardized you really are. We do have protocols in place to guide antibiotic selection. One thing we found was an opportunity to improve order sets, make them a bit more clear, make it easier to always pick the right antibiotic for the patient, especially in cases like colorectal where you need 2 agents, making sure that those both get selected in perhaps one box instead of 2 separate boxes. The skin prep products, which we spent a lot of time looking at in this study, appear to be more of a service line or surgeon selection, depending on their preference card when they set up for their case. So we certainly recognize that there's opportunity to further standardize that. We know the evidence calls for an antiseptic agent with alcohol. And as you can see in the study, and I think we'll discuss a little bit more, there was a variety of agents at use. So there's one area with opportunity to standardize for sure.
Yeah, I think it's really funny because I feel like we've encountered similar situations where we think that there certainly must be alignment with some of these standard practices. And then when we dig deeper, that is not always the case.
Yeah, and I think one thing to add to that, sorry, is the fact that I think with such the chaotic time during COVID and getting out of the OR and then getting the OR back up and running, we just had this, what we call just a normalized deviance. It was just, we slowly diverted from our standard protocols. And then and this study really showed how far we got from what those protocols used to be and what we thought everyone was doing. So it was just really interesting to see how that occurred over time.
Yes, if this were Lord of the Flies, if COVID were Lord of the Flies and it's survive as you can, everybody did stray far away from what we had been doing. And we all know that depending on the type of data that you're looking for, it can be pretty challenging to find in those patients' charts. Were any of the modifiable data pieces already part of discrete fields that you could easily query?
Yeah, so we had a phenomenal data analyst that pulled this data for us. He was able to get most of what we pulled in a discrete field, and so that was really nice. So we had a field for skin prep, CHG bathing, antibiotic administration, the ASA score, et cetera, et cetera. We also did have to, one of the manual things that we did look at was the antibiotic appropriateness. So we have a regional recommendation for our system on what antibiotics we need to use per surgery and surgery type. And so with those guidelines, we basically had to pull what antibiotic was given and then what time the antibiotic was given and what time incision started coming. So it was a very, very time-consuming, tedious process to make sure that we had what type of antibiotic was in there, and then looking to see what procedure type was performed and if the timing and the type of antibiotic was appropriate. So a lot of late nights slaying over the data set to make it right.
Yeah, a lot of time and human resource. Were there? Those are big challenges in collecting the data elements. Were there any other?
I think we had a couple other challenges just with pieces that were missing or that didn't make sense. So we did have some records where the patient temperatures were far too low, and we knew they had to be an erroneous record. And so we did some manual validation going back in and correcting those or finding the correct value, or if it truly was recorded and looked erroneous, then we needed to exclude it. We also had to go through and remove duplicates. With NHSN, if you've got an NHSN coded procedure through the incision, you can have multiple of those. You can have a colo and an XLAP at the same time, but we didn't want to skew the denominator data with the same patient's line in there multiple times for those multiple procedures in the same trip to the OR. So there was quite a bit of, like Sara said, there was quite a bit of tedious data cleanup to do to make sure that we had a nice data set to work with. And the data analyst, Zach Felix, he had to modify what we had pulled multiple times as we found, we need to pull it from this field in the record instead. That'll be more accurate, back and forth like that. So can't thank him enough for the work he did to build us this data set.
Yeah, that sounds like definitely a lot of time and manpower to get all of that done and to get your data used. So once you had that cleaner set of data, how was the data analyzed to determine whether there was some significance found in there?
Yeah, so we did a univariate analysis to assess the frequencies, the proportions of the covariates, and the odds ratios to compare and identify the potential differences in the preventative factors between the SSI and the non-SSI. We also did a bivariate analysis on each covariate to determine what odds were associated with an outcome of an SSI. And then as we were diving into the data, we were really noticing that there seemed to be some association with the urgency of the case, if the case was elective, urgent, or emergent, and what those outcomes were, and if those modifiable risk factors were completed. And so we ended up doing a secondary analysis that evaluated the association of the case classification and those modifiable risk factors to see if there really was an association between urgency and the risk factors. And so as Jordan said, our very talented MPH student who couldn't join us today, Tracy Plummer, she was phenomenal in getting this analysis done.
That's fantastic. And so digging a little bit deeper, which surgical procedures were the data collected on? And of those procedures, which were more likely to result in SSI based on this analysis?
So we target all of the NHSM procedures. So based on those ICD-10 codes, we had your colons and the hysterectomies and the vaginal hysterectomies and the cranies, all the procedures that NHSN codes and allows us to put into NHSN for reporting and analysis. And within our cohort, we ended up having 96 SSIs in the study. And the colon procedures, of course, the highest risk procedure accounted for 15% of those SSIs. And then that was followed by laminectomies and limb amputations, which is the procedure types with the most SSIs.
Interesting.
Yeah, and I think that the study noted that in urgent and emergent cases, some of the modifiable risk factors are more likely to be missed. So could you talk a little bit about that, and if based on the analysis that might have led to increased infections in those type of cases?
Yes, it was really interesting finding. So we did find that urgent cases were two times more likely to get infected, which is definitely scary. And then when we really started diving into the urgent cases, we figured out that some patients, you are hanging out in the hospital anywhere between 6 to 24 hours before you go into surgery. And it wasn't the fact that there wasn't enough time, because often we hear in healthcare, there's not enough time to get these preoperative pieces in place. We can't quite get that pre-op bathing with the CHG wipes in place or the correct antibiotic because we're too rushed. They urgently need to go to the OR. And when we really looked into it, actually, we wanted to look at the process, because if they're sitting around waiting to go to surgery or figuring out exactly what type of surgery they're going to have, there's definitely preoperative factors that we can take into account that would help keep the patient safer during surgery.
Exactly. Yeah. There's usually a minute or two of downtime that you can do a lot of that stuff. And so I'm curious too, if there was a statistically significant difference in the outcomes for patients with non-modifiable risk factors like BMI, age, surgery length, wound class, et cetera.
Yeah, so we did not find, interestingly enough, that the BMI was not found to be significant in the study, although we know other papers have described it as a significant risk factor, and for SSIs and, of course, other postoperative complications. We did find that the longer surgery length was associated with a significant risk in infection, and that makes sense. If the longer a patient is open, the increased risk they have of getting an infection. Wound class was another obvious one that was associated with an increased risk of infection, and it's nothing we can do anything about, but definitely having a dirtier or contaminated wound is going to put you at higher risk. Right. And then the common one that we're working on to this day is the diabetes diagnosis, definitely more likely to develop an SSI.
So in thinking about some of these risk factors, you mentioned earlier on antibiotic selection and timing was one of the pieces that was reviewed. Did you find any significance there around the timing or the specific antibiotics that were selected?
Yeah, so we looked at these factors individually and then together. So if the correct antibiotic was selected, we would also then look at timing, and we created a variable in the fun manual abstraction of it all for if the antibiotic was given, the correct antibiotic was given, as well as the time. So it was a yes or no, looking at both of those factors. And so if they were given the right antibiotic, but it was given too late, then it would be considered a no in that variable. So when we looked at that, when the antibiotic administration was incorrect with either the timing or the selection of antibiotic, they actually had a 2.5 times greater odds of developing an SSI. If you look at if you ignore the timing and you just look at what type of antibiotic was chosen, the odds ratio increased slightly to a 2.9 greater odds of developing an SSI. So definitely a notable increase for a risk of developing an infection when those antibiotics aren't given appropriately.
Wow. Yeah, that's something to consider for the future then as we work on surgical site infection prevention. And did you also notice any difference in the patients that used the CHG wipes versus those that did not?
We found with the pre-op bathing, with the CHG wipes, it was not a significant of a risk factor for SSI. However, we do know that many of these patients come in and we don't know what they've done before they walk into the hospital. So always making sure they're clean is definitely a recommended practice. We did look at skin prep, so what type of skin prep the patient received in the OR, and we found that if patients received povidone iodine, they had a 2.8 times greater odds of developing an SSI. So definitely identified an opportunity to standardize skin prep products.
Yeah, I'm intrigued that there were so many options available for skin prep, though. As you mentioned earlier, it's physician preference, but is that something that the hospital intends to standardize moving forward?
Yeah, absolutely. Thanks, Nicki. We were intrigued by it too. Like we mentioned earlier, just when you get the opportunity to look at this volume of data, the amount of drift or normal deviance that you find is really interesting. There's reasons for some variation, right? So emergent cases often need the povidone iodine, the truly emergent cases where they don't have time to wait for the CHG to dry. Cases involving mucous membranes, you'll see povidone iodine used. Some neurosurgeons have reservations about using CHG near neural tissues as well. So there's some variation that's needed, but the variation that we're really working to remove and standardize is the options that don't have alcohol. So we know that the evidence says we need an antiseptic with alcohol, and there are products out there that have the povidone iodine and the alcohol instead of just povidone iodine. And also we had cases where chlorhexidine was documented by itself versus the ChloraPrep, which would have the alcohol. We want to see if we can get ourselves down to 2 or 3 standardized options. Make it easy to do the right thing if you've only got a couple of the correct options stocked. You've got something for emergencies, something for mucous membranes, and then something that's standard for everyone else. Definitely something we're working towards.
So what do you think the hospital is planning on doing differently based on the results of the study? If protocols weren't already in place, is the hospital going to implement evidence-based policy and procedure, or what's going to happen?
Yeah, we've made a couple changes already to our order sets. The biggest thing was the order sets to get the correct antibiotics in there. Earlier, when Sara was describing the odds ratios with not receiving the right antibiotic, that of course really stuck out to us as a significant concern and should be fairly easy to correct. So one quick thing we found was actually for our colorectal cases, the surgeons were having to check 2 boxes to get both cefazolin and Flagyl ordered. So we put them on the same line and they just check 1 box. Easy switch. Now they can get both the correct antibiotics in there. Yeah. And then we have an infectious disease pharmacist who's always reviewing these order sets. And so I know that over the last year, she's done a lot of work to standardize these and ensure that the different service lines have the correct evidence-based antibiotic on there.
It's good because it makes it easy. And that's how you get things done. Make it easy.
Yeah, one of the next things we're trying to work on too is the timing. So we do have some things that take longer infusions like vancomycin and ertapenem. The timing is not quite as easy to engineer into something like an order set. Sure, so yeah. Really partnering with our pre-op teams on the importance of those infusions starting early enough.
So I think both Nicki and I really appreciated the study, and it's aim to establish processes to prevent the disruption of best practices during these times of upheaval, like a pandemic, which we hope we never have to experience again in our lifetime. So as part of this, what were some of the strategies that your hospital is now determined that they're going to implement to achieve less disruption if something like this were to happen again?
Yeah, I think this is a great question. And I think a lot of it comes to standardized workflows, utilizing our electronic medical record to make it easy to do the right thing, like we were talking about with the antibiotics in the order sets. I think stocking the correct products. Something that's challenging is education. And that was another factor that actually we haven't talked about and didn't assess in the study, but most of your in-person, if not all of your in-person education and orientation went away during the pandemic, right? Yeah. So then we were relying on people reviewing these online modules, expecting that they knew what to do. So that's one piece that I think we still have to consider is how do you really standardize that onboarding process for new staff. And I think when you build the standardized workflows for them to use, that'll help make it easier for them to come on and have the process, have the protocol, have that workflow there, and always be doing the right thing.
Any thoughts from you, Dr. Reese, on that?
No, she, I think, covered it quite well. It's just making sure we make it easy for everybody. And that's the biggest thing, because if we don't set them up for success with the right process, we're not going to be successful. So just making sure it's as easy as possible to make the right choice.
Yeah, I agree. Easy is always the best way to go. And how will the hospital then monitor that these best practices are consistently used across all the surgical services? You mentioned earlier on that we started to drift away from our standard practices during a situation like this. Is there a plan in place for actually monitoring?
Yeah, again, with data, and another shout out to Zach, our data analyst, but he has been able to build us a lot of dashboards to watch these process metrics. So our OR has a dashboard that they look at daily, definitely weekly, I think mostly daily. And they're looking at all sorts of process measures on there, room turnover, a lot of their operational pieces. And they also have on there measures like the first temp in the PACU. So if they start to see more patients who are coming into the PACU cold, that's an early signal to our OR to take a look at what they're doing and making sure that they're maintaining that normothermia. Antibiotic timing is also on that dashboard. So some of those real-time process measures that we can watch and hopefully start to see that drift earlier before it leads to infections and increased outcomes. The other process we implemented coming out of this study was an apparent cause analysis team to review our SSI cases. I think this study showed us just how much we didn't totally know until we got our hands on all the data. And so the apparent cause analysis gives us the opportunity to do a deep dive into each individual case, and then we really can see what's going on. And that continues to either reaffirm some of the practice changes, like normothermia, for example. In our ACAs, we've found mostly that our patients are warm enough. And so that's been great to see that we've had an impact. When we're looking at these cases, we're succeeding in some of these measures where we've been working for the last couple years. And so we'll continue to do that. We'll be watching the data. We'll be watching those process measures. Of course, we'll be doing our surveillance. We'll be doing our apparent cause analyses. And I think just keeping that team engaged in those ACAs and in our task force work hopefully will really help us to maintain our success and our best practices across the surgical specialties over the next couple of years.
That's really wonderful. Thank you so much for sharing.
Absolutely. It's just good work when so much stuff got derailed with COVID. So it's really nice to see us digging back into practices, restandardizing, and getting back on track. So any takeaways for the listeners before we close out?
I think just Jordan really highlighted this whole apparent cause analysis. I think we, as infection preventionists, really spend a lot of time focusing on CLABSI and CAUTI and, of course, colon SSI as the big reportable infections. But I think really taking time to review those cases and review them with the perioperative team, including your surgeon and your service line leaders, and having that open line of conversation and that relationship is just imperative. And I think that Jordan has definitely demonstrated a great model that infection preventionists should utilize moving forward, because it allows everybody to be open and transparent and discuss opportunities and how can we partner to fix it, instead of the IP traditionally sitting in their office doing surveillance and hoping for the best. So it's definitely a great model.
Yeah. Absolutely. Jordan, any takeaways from you?
Yeah, I think I would just add, get into your OR. Take a look around. You might not have a student who can analyze 8,000 records for you, but you can go into the OR and ask them, hey, tell me about your skin prep products. And you might be surprised. You might find a whole bunch of variation, or you might not. But I think just getting out there and seeing what's going on, observe some cases, get to know those frontline teams. That way you can be there to help and support through these times of change as well.
Fantastic.
Fantastic.
Thank you for joining us today. We are Nicki Shore and Jessie Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business.
AGIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the FAPIC Center of Research, Practice, and Innovation, and Pat Stone and Jean Brandt at AGIC and APIC staff, Rebecca Bartles, Ria Gupta, Bobby Gulshan, and Liz Garman. We work in partnership with Human Factor and Audio Tech's Blake Alton and Carolyn Schneer. To hear other AGIC episodes and to access information about this podcast and the field of infection prevention and control, go to our website, agicscienceintopractice.org. That's AJIC scienceintopractice.org.